And we are now ready to move to the antibiotic stewardship portion of our call. So I'm going to turn the call over to Leah Weideman, who is the antibiotic stewardship epidemiologist for our team. So Leah, please go ahead.
Hello, can you confirm that you can hear me all right?
Yes, we can hear you.
All right, fantastic. Tina, thank you for the introduction. I'm the antibiotic stewardship epidemiologist here at the Philadelphia Department of Public Health. Happy U.S. Antibiotic Awareness Week to all. Today, we have an exciting guest joining us, Dr. Jerry Jacob, who's an infectious disease physician, the director of antimicrobial stewardship at Good Shepherd Penn Partners Rehabilitation, and an associate professor at the University of Pennsylvania. He will be joining us to talk about penicillin allergy delabeling, which is a valuable tool for stewardship programs. But before we jump into that, I'm going to give a brief history on the discovery of penicillin before handing it off. So thank you for being here. Next slide, please. Oh, yeah, there we go. All right, so this story starts in England in 1928 when Dr. Alexander Fleming, who was a Scottish bacteriologist, returned from a long vacation to a very messy lab bench. And when he was sifting through his culture plates, he noticed one in particular that was dotted in staphylococcal colonies, but there was also a mold called Penicillium notatum growing on it. And in the area immediately surrounding this mold, the staphylococcal colonies weren't growing. In fact, they were actively dying and undergoing lysis. And as any good scientist does, he worked to replicate this experiment, and in doing that, found that whatever substance was produced by this Penicillium notatum, this substance had an activity against very many types of bacteria, not just staphylococcal bacteria. He worked pretty hard to try to purify this substance, but found that it was unstable and he was no chemist. So he wrote up his findings and really only mentioned the potential therapeutic properties of this substance that was produced by penicillium, which he called penicillin, in passing. Next slide, please. Thank you. So fast forward 10 years, it's 1939. We're still in the United Kingdom at the University of Oxford. And Dr. Flory, who is a pharmacologist and a pathologist, and Dr. Heatley, who's a biochemist, become interested in the therapeutic properties of penicillin, and they ramp up research. But in 1939, as we know, war conditions were starting to make research very difficult. And penicillin, they were finding, was also really difficult to mass produce. In fact, they found that 2,000 liters of mold culture fluid were needed to treat a single case of sepsis. And under these war constraints, they started to try to grow penicillium in very strange culture vessels like baths and bedpans and milk churns and food tins. And it simply wasn't sustainable. So they ended up moving research to the United States in the early 1940s in Peoria, Illinois. And here you can see pictured on the right are the early forms of equipment that were used to make penicillin. And they were so desperate for a strain that was more productive than the strain that Dr. Fleming wrote about, that they sent their lab assistants out to pick up fruit from grocery stores. And the species of mold that was found to yield enough penicillin for mass production came from a regular old cantaloupe picked up at a grocery store in Illinois. It's called Penicillium chrysogenum. And after some modification with x-rays, it was 200 times as productive as the strain originally identified by Dr. Fleming. Next slide, please. So the impetus really for scaling up penicillin production so quickly was World War II. Of course, combat-related injuries were the leading cause of death for soldiers, but this was followed pretty quickly by infectious diseases, sustained from living in barracks or from infected wounds. And the goal was to have enough penicillin to send with soldiers on the D-Day invasion in northern France and Normandy. And this goal was met. Thousands of doses were sent with US troops to support the D-Day invasion. And the death rate from bacterial pneumonia in World War I was 18%. During World War II, this dropped to merely 1%. Next slide, please. By 1945, mass production was well underway and penicillin became widely available, worldwide. So in less than 20 years, from 1928 to 45, penicillin went from being a relatively unknown substance produced by a relatively unstudied mold into a medicine that has transformed infections that used to be deadly into very easily treatable conditions. And our goal as antibiotic stewards is to preserve the efficacy of penicillin and other life-saving antibiotics. And so again, here to talk about one tool in our toolkit, penicillin allergy delabeling, is Dr. Jerry Jacob. So I will hand it off to you to talk about penicillin allergy delabeling. Thank you.
Thank you so much, Leah. Can you all hear me?
Yes, I can hear you.
Great. Okay. That was a wonderful lead into what we're going to talk about today. It's good to be with you all. I want to thank the Department of Public Health for inviting me to speak today about a topic that is near and dear to my heart as an infectious disease physician, and that's penicillin allergy delabeling. And I'm going to talk about it specifically in the context of long-term care. Next slide, please. So my goals for the talk today are first to describe to you the burden of unverified penicillin allergy labels that exists out there and the potential impact this has on health outcomes. Second, to highlight what I think is a unique opportunity for delabeling these patients in post-acute settings, including skilled nursing facilities. And finally, to provide some practical resources that have been put together for implementing a delabeling protocol in your community. Next slide, please. So first, some background. Penicillin allergies are reported by about 10% of the overall population. So about 1 out of every 10 people that you meet will have a penicillin allergy label on their health record. If you look specifically at hospitalized patients who are more likely to receive antibiotics because they're more likely to have infections, the proportion actually increases to 20%. So 2 out of every 10 patients who are hospitalized, who have recently been in the hospital, are going to have a penicillin allergy reported on their record. Next slide, please. Now, those are the labels that we talked about on the last slide. If you look at the actual prevalence of true penicillin allergies, that is skin test proven allergies, it's actually less than 1%. So there's a substantial gap between the proportion of patients that have the label on their record and the proportion of patients that actually have a true penicillin allergy. Next slide, please. So another way to say that is that more than 95% of patients with a penicillin allergy label are actually able to tolerate penicillins. So if you think about that, there's a lot of people who are walking around with a penicillin allergy label on their chart that is inaccurate. And there are a few reasons for this. One reason is that penicillin allergies tend to wane over time. So even if a patient had a true penicillin allergy at one point, that allergy will fade over time. About 80% of patients will lose their allergies over the course of 10 years. And most of the penicillin allergy labels that we see were placed during childhood. Another reason is that it may not have been a true allergy in the first place. So sometimes the allergy label is put onto a chart when a patient experiences side effects that aren't necessarily an allergy from a medication. So things like nausea or diarrhea or headache, which are true side effects, but not necessarily an allergy that would preclude use of all penicillins. And finally, if you look at studies of skin test proven allergies, there's actually been an overall decline in true penicillin allergies over the past 50 or so years, probably related to the way penicillins have been formulated in the past and how they're formulated now. Next slide, please. So why is this important? Well, penicillins are part of a larger family of antibiotics called beta-lactams. And I listed there some of the more common examples of beta-lactams that we use. So amoxicillin, which I'm sure everyone's heard about, amoxicillin clavulanate or Augmentin, Keflex, Ceftin, Vantin, Cefazolin or Ancef is the trade name, ceftriaxone, meropenem. Those last 3 there are antibiotics that are commonly used for patients who are in the hospital, and they're often discharged on those antibiotics to skilled nursing facilities. So if a patient has a penicillin allergy listed on their chart, there's often hesitation to use any of these other antibiotics as well. Amoxicillin and Augmentin are part of are considered penicillins, and these other antibiotics are in related classes called cephalosporins or carbapenems. And so because there's a concern that there could be cross-reactivity between these antibiotics, if a patient has a penicillin allergy on their chart, providers will often avoid all of these antibiotics. So it closes off a lot of different antibiotics as options for the patient. Next slide, please. And this is particularly important because beta-lactams are actually the first-line antibiotic choices for many infections. Some of the more common ones we can think of are strep infections, skin infections, and respiratory tract infections, which we see commonly in long-term care facilities, dental infections, syphilis. Beta-lactams are safe. They tend to be well tolerated, and they tend to be better killers of germs than some of the other antibiotic classes that we have. Next slide, please. So what that means is if a patient has a penicillin allergy label on their chart, they often will not receive beta-lactams, and so they'll receive a second-line or a third-line antibiotic. And that's associated with negative health outcomes that have been demonstrated in studies, including longer hospital stays, C. difficile infection, treatment with less effective or more toxic antibiotics, and an increased risk of drug-resistant germs. What you see on the right here is a flyer from the American Academy of Allergy, Asthma, and Immunology that indicates that patients reporting penicillin allergies experience 10% more hospital days and up to 30% higher risk for numerous superbug infections. Next slide, please. So to summarize what we've talked about, and this is from a paper that was published in the New England Journal of Medicine, penicillin allergies are typically acquired, or the label is typically acquired in childhood, and up to 20% of the population that is engaged in medical care is labeled as penicillin allergic, which has a number of different ramifications. In terms of personal health implications, it means there's fewer efficacious antibiotic choices, there's more toxic effects associated with alternative antibiotics. These patients receive more broad spectrum antibiotics, and they have more postoperative surgical site infections, which I didn't mention earlier. But there's also public health implications. So if you use these second or third line antibiotics, they're more likely to lead to antibiotic resistance and produce higher rates of C. difficile infection, which can spread between patients. It leads to use of more costly antibiotics and an increased length of hospital stays. And finally, as we've mentioned, if you actually formally assess these patients for an allergy, less than 5% of them are actually labeled as allergic to penicillin, or actually truly allergic to penicillin. Next slide, please. So that was the background. Here's a quick pop quiz to just recap what we've discussed. And the question is, which of the following is not a common myth about penicillin allergies? A, penicillin allergies last throughout a person's life. B, should be penicillin allergy labels are harmless. C, the large majority of patients with the reported penicillin allergy are able to tolerate a penicillin. Or D, patients with penicillin allergies can always receive a different but equally effective and safe antibiotic. So the question is really, which of these statements is actually the true statement? So I believe we have a Zoom poll up, and we'll give everyone a moment to respond to that. Okay, can we click forward and see the results? All right, great. So most people picked the correct answer, which was that the large majority of patients with reported penicillin allergy are able to tolerate a penicillin. So just talking briefly about the other options, penicillin allergies do not last throughout a person's life. For most people, those allergies will go away after 10 years. Penicillin allergies are associated with some harms, and there are not always equally effective and safe antibiotics available apart from penicillins and related beta-lactams. Next slide, please. Okay, so now that we've given some background on penicillin allergy labels, I want to talk specifically about these labels in long-term care facilities. And we don't have a lot of data in these settings, but this is increasingly being recognized as an area of opportunity and increasingly being called out in the literature. So what you're seeing on the slide here are results from a study that was published in 2024, where they did a survey of 20 long-term care facilities in Massachusetts. And what they found was that 23.1% of residents reported penicillin allergies. So that's a little bit higher than the rate we talked about for hospitalized patients. There were significant documentation gaps noted. Up to 92.8% of records were incomplete. That means either didn't specify what the allergy was or what the antibiotic was. Among patients who received antibiotics in the past 30 days, more than a third of them had a documented penicillin allergy. So that means the patients for whom this has the greatest impact, that is those who receive antibiotics, there was an increased proportion of them that had a penicillin allergy. And finally, residents with penicillin allergies were 95% less likely to receive beta-lactam antibiotics for any infection, which again, those are generally the first line antibiotics that we use for a lot of common infections. Next slide, please. And just to hammer this point home, I'm going to just walk through a hypothetical case here to demonstrate what the impact of having these labels on the chart is. So you have a 79-year-old male with heart failure and a recent hip fracture who develops cough, rigors, and a fever to 101. Other vital signs, including pulse, respiratory rate, and oxygen saturations, are normal. The chest X-ray suggests a pneumonia. After reviewing the RFAST tool, and if you don't know what that is, I'd encourage you to look at last month's slides, or if when you receive these slides, you can click on the link there. The clinical team identifies that the patient has met minimum criteria for initiating antibiotics. Although amoxicillin clavulanate, which is also known as Augmentin, is preferred first-line therapy, the resident has a penicillin allergy listed on the chart. So amoxicillin clavulanate is considered a penicillin, and so there's a contraindication to this drug listed on the chart. Details of the reaction to penicillin are currently unknown, and therefore second-line therapy with levofloxacin is started. So what are the potential risks with using levofloxacin instead of amoxicillin clavulanate? So levofloxacin is part of a class of drugs called fluoroquinolones. It's one that we use commonly, but it does have some notable side effects. One is that it has an increased risk of C. difficile infection, of Clostridium difficile. It has, especially in elderly patients, an increased risk of causing confusion. It also can potentially prolong the QT, so it has some potential cardiac effects and has effects on tendons as well. Now, this is not to say that we should never use this drug, because there are certainly reasons to use levofloxacin where it's the most appropriate option. But it just demonstrates the potential for what a penicillin allergy label can do in terms of increasing risk for these outcomes. If you can click through. Next slide. Yep. So for example, sorry, you can go back one. If levofloxacin is started, this is hypothetically 48 hours after it's started, you do an antibiotic timeout, fever is resolved, cough is stable to improving, but the patient develops confusion. Levofloxacin is continued for 5 days because that's the standard course we use for pneumonia. And on day 4, the patient develops diarrhea and tests positive for C. difficile. He subsequently started on a course of oral vancomycin for C. difficile infection. So it's not to say that amoxicillin clavulanate would never cause these types of complications, but the risk would be significantly increased with levofloxacin. Next slide, please. So what can we do about this problem? It's important to define our terms first. So penicillin allergy delabeling is the process of removing a penicillin allergy label from a patient's medical record after an evaluation confirms that they are not allergic. Alternatively, you can relabel or update a penicillin allergy, and that's the process of clarifying an existing label that's on a patient's chart. So that may mean clarifying whether the allergy is to penicillin or another beta-lactam antibiotic, or indicating what the actual reaction was to the penicillin. Next slide, please. I believe there's a unique opportunity for delabeling in the post-acute setting for a number of reasons. One is that the patients who are in post-acute care, and this includes skilled nursing facilities, rehabs, LTACs, they are at increased risk of antibiotic utilization and adverse outcomes. They've been recently in an acute setting and so are more likely to pick up infections. They're also, when they're in post-acute care, in a supervised care setting for generally at least a week, which means there's an opportunity to assess their penicillin allergy label and to do a history and to potentially challenge them and follow them for a few days after the challenge with the penicillin. They also generally do not have acute medical issues, which would, prevent delabeling efforts, on the acute care side. And finally, there's the potential impact of this. The Department of Public Health team ran some rough numbers and found that over a year, there's potentially more than 1,300 residents admitted to Philadelphia skilled nursing facilities that may be falsely labeled as penicillin allergic. There's also a study published earlier this year that looked specifically at older adults with low-risk penicillin allergy histories and found that about half of them, half to two-thirds, could potentially be delabeled just based on the history alone. Next slide, please. So we mentioned earlier that I'm actually a director of antimicrobial stewardship at Penn Rehab, and we started our delabeling efforts in 2020, and over the course of a couple years, we're able to evaluate 145 different patients for penicillin allergy delabeling. And of that, we were able to delabel 30 patients by history alone. So that's about 1/5 of the patients by history alone. If you look at those 30 patients, we delabeled about a quarter of them because the reaction was not consistent with an allergy. And we delabeled about 3/4 of them because when we looked in their medical record, they had actually received penicillins safely without any adverse effects. And it's surprising sometimes, but a patient will have a penicillin allergy label on their chart, and then you look back in their hospital record or their outpatient record, their MAR, and find that they've actually received either penicillin or amoxicillin clavulanate or some of the other penicillins, which they would not be able to tolerate if they had a true penicillin allergy. And so those patients can also be delabeled. So it just shows you the potential impact we can have simply by taking history and reviewing the medical record regarding penicillin. Next slide, please. So how do we delabel a patient? So the first and most important step is a history and a record review. And if that review indicates that the prior reported reaction was not consistent with the true allergy, the patient can be delabeled or the existing label can be clarified. If the history and record review suggests that it potentially is consistent with the true allergy, in recent years, there's been a fair amount of literature that has validated a scoring system called the PenFast score. It's essentially a list of 4 different criteria, and if you meet 3 or more criteria, you're a higher risk for having a true allergy, or 2 or less, it's a lower risk. And that basically helps determine whether the patient would need skin testing prior to undergoing a direct oral challenge. A direct oral challenge with amoxicillin is really the gold standard for delabeling a patient. If they can tolerate an oral challenge with amoxicillin without an adverse reaction, then they can be delabeled. And so we're not going to talk specifically about the PenFast score here. I have a slide all the way at the end of this deck, which has the actual score there if you're interested in learning more. Next slide, please. So what are the history questions we ask? They're fairly straightforward. Which penicillin did the resident react to? How long ago was the reaction? Because again, if it's in more than 10 years, it's more than likely that they're no longer allergic. What symptoms did the resident have? Were they actually consistent with a true allergy, or was it a potential side effect from the medication? How long after taking the penicillin did the patient have a reaction? So a true allergic reaction or anaphylactic reaction will typically start within 30 minutes to an hour after taking the drug. And finally, has the resident taken a penicillin or related antibiotic since the reaction and tolerate it? Because if they have, that would be the end of the assessment, and you can actually delabel them at that point. Next slide, please. All right, you can click through one more time. So I'm going to focus specifically on this bottom portion of the flow chart here and how we can implement this in a long-term care setting. Next slide, please. All right, so this is a new resource that was put together by the Department of Public Health team, and I've taken a look at it as well and reviewed it with them to help implement a delabeling program within your facility. So this is a penicillin allergy delabeling SBAR I'm sure you're all familiar with SBAR's situation, background, assessment, and recommendation. And just to go through this form briefly, at the top you see some demographic information as well as who the form was completed by. In the background, you can see the potential reasons for an assessment, a routine intake, potential antibiotic stewardship or quality improvement initiative, or perhaps the resident has a condition for which a beta-lactam would be preferred treatment, and that's the reason you're doing the assessment. We only want to do this assessment on residents who are able to provide an accurate medical history. So if they have a diagnosis such as dementia or cognitive deficiency or an altered mental status that would preclude them from providing an accurate medical history, we would not proceed with the assessment. Similarly, if they relied on a healthcare proxy to make their decisions for them, we would not proceed with the assessment either. The assessment includes an algorithm, and I'll go through that on the next slide. And you would work through that algorithm, and the conclusion from that would be either that the resident is eligible to have their penicillin allergy removed or updated based on history alone, or they're not eligible. And then you'd make a recommendation based on that to consider removing the penicillin allergy or referring them to a specialist for a direct oral challenge, or maintaining the label as it is. Next slide, please. So this is the algorithm. I won't go through it in too much detail, but essentially there are two endpoints here. In blue, the patient could potentially be delabeled, and so you would ask the resident if they would agree to removing or updating the penicillin allergy label, and then send this form on to a provider to review, or in orange, in which case the patient would not be eligible, you would not remove the label, and you could provide the resident with that information. It's a series of 4 questions or 5 questions here. Fairly straightforward. Do you know or remember anything at all about your past reaction with the penicillin? So these are questions you'd be asking the resident. Have you ever actually received a penicillin and experienced a reaction? Why is the penicillin allergy on your record? What are the names of penicillin-related antibiotics that caused your reaction? What symptoms did you have with your reaction? And since the reaction occurred, have you tolerated any of the following penicillin antibiotics without having a reaction? And some of this may actually be already existing in the record if the resident can't remember. The bottom left-hand corner there, you can also see the various antibiotics that fall within the penicillin and related beta-lactam classes. Next slide, please. So how can you use this SBAR? So first, you can use it to identify patients who are eligible to have their penicillin allergy labels removed. This could be all patients within your facility or specific ward who have a penicillin allergy label, or you could prioritize those patients who have recurrent infections or perhaps need a beta-lactam antibiotic for a specific infection. It could be administered by a consultant pharmacist or a nurse, and then reviewed by or escalated to a physician or medical director for a final decision on delabeling. And then it's very important to document it and include it as part of the resident's medical record. I can tell you that some of these penicillin allergy labels can take on a life of their own. And sometimes even if you remove it from the record, it may continue to exist in a separate medical record, say in the primary care office or in a hospital record. And if it continues to exist there, it can potentially live on and potentially show up on your chart again. So ideally, you would remove it from your record and then let the patient's other providers know as well that that penicillin allergy label can be removed from all of their different medical records. Next slide, please. So, penicillin allergy delabeling programs can qualify as an antibiotic stewardship QAPI program, which are, there are CMS requirements around having QAPI programs, so this could qualify for that. And the recommended, quality improvement approach for QAPI programs is the PDSA cycle, which I imagine some of you are familiar with, which is it stands for Plan, Do, Study, Act. And so we're going to walk through what this might look like specifically with this, with the penicillin delabeling, penicillin allergy delabeling program. Next slide, please. So the first part of PDSA is to plan. So here you would define the intervention, establish a goal, identify steps needed to execute the intervention, and the data to be collected. So as just one brief example, you could write, we plan to test an SBAR protocol for removing penicillin allergy labels from residents' medical records based on medical history alone. Our goal is to complete and document the SBAR for every resident on Ward X with a penicillin allergy listed on their medical record. We will collect data on the number of residents evaluated using the SBAR, the number of residents with penicillin allergies removed, and the number of residents with penicillin allergies updated. And finally, the SBAR will be implemented and data will be measured with the following steps. And so this is just an example. You could tailor this to your community and to how you'd want to formulate your specific program. Next slide. So the D stands for do. This is where you carry out the program and document your results. So continuing the example, the first cycle of this SBAR protocol was started on so-and-so date and completed on so-and-so date. The data was collected. Feedback was obtained from staff and patients. Important to obtain feedback as you think about how to improve the intervention for a subsequent cycle. Next slide. The S stands for study. Here's where you'd analyze the results collected during the do phase and determine whether you met the goals defined during your plan phase. So for example, of X number of patients evaluated by the SBAR protocol for penicillin allergy delabeling, Y percentage of patients were successfully delabeled based on history alone. Next slide, please. And finally, the A stands for act. So you would draw conclusions about the results of your program and use these to inform future actions. So as an example, implementing a penicillin allergy delabeling program was feasible, improved care. Based on feedback, we identified one area where implementation of the program could be improved. We plan to expand use of the program to all resident admissions with a reported penicillin allergy. So hopefully that was helpful to walk through that and give you an example of how this tool could potentially be used in your communities to delabel patients. Next slide. So let me conclude with just some takeaways here. Penicillin allergy labels are quite common, especially among residents who have been hospitalized. These labels are associated with a number of different negative health outcomes. The overwhelming majority of residents who are labeled with a penicillin allergy are not truly allergic and can safely receive penicillins. A significant number of penicillin allergies can potentially be removed through history and record review alone. And finally, there are new resources available to support QAPI projects for penicillin allergy delabeling in long-term care communities. Next slide. All right, I'm going to stop there. I want to thank Leah Weideman, Tina Peretz, and Jane Gould, who helped with these slides, as well as two of my colleagues at Penn, Jumi Fadugba and Keith Hamilton, for assistance with the algorithm. I want to say happy Antibiotic Awareness Week, and thank you for all your efforts to preserve our antibiotics and to steward them well. And happy Thanksgiving to everyone. Thank you all. I'll pass it back off to Leah.
Thank you so much for that, Dr. Jacob. I'm going to cover just a few more slides, and then Dr. Jacob and I are happy to take questions.
Yeah, we can't hear you very well.
Oh.
Are you able to adjust your mic?
There we go. Can you hear me better now?
Yep.
That would be my headset. Sorry about that. So thank you, Dr. Jacob, for that fantastic presentation. We'll be happy to take questions. I'm just going to cover a few more slides. So next slide, please. All right. So firstly, the resources that Dr. Jacob discussed are available for you online. We have the penicillin allergy delabeling evaluation tool that we've uploaded to the HIP. We have also created an educational resource for residents. This explains penicillin allergies and why it's important to remove them when they're inaccurate in very plain terms. So that should help facilitate communication around this topic. So I will be sending the links for that in the chat shortly. Next slide, please. All right, and secondly, the Philadelphia Department of Public Health, we want to partner with you on antibiotic stewardship and in particular on penicillin allergy delabeling programs. And we're hoping to do that in a couple of ways for interested facilities. Firstly, we would like to pilot a project for facilities who are interested in implementing penicillin allergy delabeling programs, but may not necessarily have the capacity or ability to prioritize tracking their implementation or evaluating the success of these programs. We would like to provide support for this for facilities who are able to submit their delabeling data to us. We would be able to crunch those numbers and turn those around into reports or visually appealing and interactive dashboards that you can then have as evidence of your stewardship efforts and potentially present to CMS surveyors, for example. So if you're interested in partnering with us on data analysis and tracking your penicillin allergy delabeling programs, please get in touch. Secondly, we are hoping to begin an antibiotic stewardship focus group where we can discuss topics related to stewardship, such as the fantastic talk that Dr. Jacob gave today. In addition to that, this would be an open space to discuss the logistics or the challenges of implementing antibiotic stewardship programs, and to identify exactly how you can leverage your local health department to support you in doing this, as well as discuss with your peer long-term care facilities. Next slide, please. Lastly, I'll take this meeting as an opportunity to plug a survey. So if you are a consultant pharmacist and you have already completed this survey, thank you. The more responses we get, the more accurate our outreach is. If you've passed the survey on to a consultant pharmacist, thank you. That said, if you're in attendance of this call and you're a pharmacist and you haven't taken this yet, it would be fantastic if you could take 5 minutes out of your day to complete this survey. It'll help us develop resources that address, real needs and contribute to improved antibiotic stewardship practices at Philadelphia skilled nursing facilities. And if you're not a pharmacist, but you have a consultant pharmacist that serves your facility and you haven't passed the survey along yet, please take the time to do so. I'm going to be dropping the links to the resources that we've discussed today in the chat shortly. And that's everything from me. Thank you so much for attending. We hope that you got a lot out of this talk, and we will open up the space for questions now.
There is a question in the chat. One of the issues we are having is ensuring the hospitals update their allergy list when we send a resident to the ER or consultant visits. It is hard to get medication reconciliation completed along with allergies. How can we enhance communication?
Yeah, that's a good question. I think the handoff between hospitals and post-acute care or vice versa, something that we're continually always looking at. I can tell you, well, first let me say I'm in addition to my roles as director of antibiotic stewardship, I'm also a physician advisor to the LTC RISE team, and part of what we do is try to ensure that these transitions and care go smoothly. So all of your facilities should have a LTC RISE navigator who assists you and who also help with these transitions. So if you're having an issue with the transition, particularly to Penn hospitals, which I can speak to, then we want to hear about that. We want to know that, and we can certainly escalate that to address whatever the transition issue is. But it's particularly for medication reconciliation and allergies, which are high risk areas. I think we can improve communication there. So I'd certainly want to hear about that from you. I think any way that you can, if there's direct communication is always better. Sometimes we'll get patients sent from SNFs to the ER, and we'll rely on the documentation that comes with them. And sometimes documentation doesn't cover everything that the ER is necessarily looking for, or the hospital team. If we can open up the lines of communication where we can call directly or find some way to communicate directly with the ER about the patient and the issues, that can help as well. Those are just some preliminary thoughts, but happy to chat with anyone specifically about any specific issues you're dealing with.
Do we have any other questions at this time? We can also take questions at the end if you think of additional ones that you haven't quite formulated yet.